We present our video of endoscopic management of bilateral UVJ obstruction in an infant. The patient was a healthy full-term, 1-month-old male with normal prenatal imaging who was admitted in renal failure to our institution after 24 hours of anuria. His admission labs were notable for a creatinine of 2.3 with electrolyte imbalance. A renal bladder ultrasound showed bilateral P3 urinary tract dilation with no prominent ureterectasis and mildly echogenic parenchyma. The following day, although he had made some urine through his catheter, his creatinine continued to rise and new ureterectasis and free fluid outside the kidney was seen. Thus, the patient was taken to interventional radiology for bilateral nephrostomy tube placement. At the time of placement, there was no clear passage of contrast past the UVJ into the bladder. The patient did well following the procedure and his creatinine returned quickly to 0.3. However, after a staggered capping trial of his percutaneous nephrostomy tubes, he had recurrent anuria with a slight bump in creatinine. An MR urogram showed again that the level of obstruction was the ureterovesical junction. The family was counseled on their options, including open surgical management, but elected instead for endoscopic management if possible. The patient was taken to the OR for cystoscopy, where bilateral ureteral orifices were noted in orthotopic position. The left ureteral orifice was first addressed, where the UVJ was notably tight around a 3 French open-ended catheter. However, it was able to be advanced through the dilated ureter and mid-ureteral kink, as shown here on fluoroscopy. A 4 French tapered catheter could not traverse the UVJ, so we opted to incise the ureteral orifice using the holmium laser. The 150 micron laser was utilized on low settings of 3 Hz and 400 millijoules to open the lip of the orifice at 12 o'clock. This was enough to admit the tapered 4 French catheter. After a series of wire changes, a 4.7 French by 14 cm stent was placed across the UVJ, through the redundant ureter and into the upper pole. On the right side, there was a similar tight feel to the UVJ, but a wire and a 3 French catheter were able to be advanced. The ureteral orifice was again opened with the laser, this time over the 4 French tapered catheter, which was used to hold the area of constriction on tension. After this, with a safety wire in place, a 4 French Fogarty catheter was inflated to further dilate the ureteral orifice and tunnel. A 4.7 by 12 cm stent was placed, and at this point, contrast could be seen actively draining from the orifice. The right nephrostomy tube was removed. We did return to the left side and performed an antegrade nephrostogram through the existing nephrostomy tube. This did not show robust drainage through or around the stent. Thus, we chose to open the left ureteral orifice further with the 150 micron laser, followed by the Fogarty balloon as we had done on the right side. The orifice accepted this alongside the existing stent easily. Following surgery, the patient did well and was discharged to home on post-op day 5. At follow-up 6 weeks later, his creatinine and renal bladder ultrasound were stable. In conclusion, treatment of bilateral UVJ obstruction in an infant poses a unique challenge given their bladder size and the desire to avoid complete diversion of urine. Endoscopic management is not always possible. However, laser and balloon dilation can be utilized to maximize the chance of success endoscopically and avoid open surgery.